All right, welcome back, everyone. Now, the next speaker is Dr. Nicole Cipriani. Dr. Cipriani is an associate professor of pathology at University of Chicago, and she's going to discuss head and neck pathology.
Thank you. So I'm going to do about 45 minutes of head and neck, and then an hour-ish of bone and soft tissue. So it's going to go fast because there's a lot of information. So please keep typing your questions in the Q&A if you have them. I will be sharing the PDFs, and I'm also happy to share the recordings for those of you who want to relax and not take notes or whatever. So without further delays, head and neck, here we go. So I'm going to go through all the different anatomic sites of the body, of the head and neck, rather starting with the squamous sites. So the first thing that clinicians might see in evaluating patients' mouths, right, is leukoplakia, erythroplakia, leuko being white, erythro being red. So these are clinical appearances of oral mucosa that histologically may represent a wide variety of pathologic diagnosis. So this is not a pathologic diagnosis, this is a clinical diagnosis. I didn't confirm, I assume you guys can all see this, yeah? Okay. The differential diagnoses of leukoplakia include oral hairy leukoplakia, which is related to Epstein-Barr virus, usually in immunocompromised patients, which shows up histologically as balloon cells. You can stain for EBV. Oral candidiasis, which can be hyperplastic histologically, but with neutrophils and yeast forms in the superficial keratin layers. Lichen planus being an autoimmune disease, mostly of females, showing granular deposits of fibrinogen at the basement membrane if immunofluorescence is provided. Certainly sawtooth reedy ridges and band-like chronic inflammation. Pemphigus vulgaris and bullous pemphigoid are our other two diseases in which immunofluorescence might be helpful, which we are going to see either intraepithelial blistering histologically with a fishnet-like pattern of immunofluorescence, or subepithelial blisters, again with band-like deposits at the basement membrane. So if your clinicians have a differential diagnosis of these three entities, immunofluorescence might be helpful. Subepithelial lesions that may appear more as either pedunculated or sessile. I put these two here together, epulous and granular cell tumor, not because the clinical is overlapping, but because the histology is. And so epulous is on the alveolar ridge of newborns with these granular cells with distinct cell borders, S100 negative, versus granular cell tumor, granular cells, indistinct cell borders, S100 and SOX10 positive because it's thought that they are modified Schwann cells, and of course classic pseudoepitheliomatous hyperplasia, meaning a worrisome proliferation at the surface that can be mistaken for cancer. Remember, epithelioma was the historic name for carcinoma, so this is pseudocarcinomatous hyperplasia, but is essentially benign. The thing that we, of course, worry about in any leukoerythroplakia is dysplasia, right? So usually these are keratinizing dysplasias that manifest eventually as keratinizing squamous cell carcinomas. You know, our usual suspects, tobacco, alcohol, even betel nut chewing in particular areas. In order to grade dysplasias in the oral cavity, it's challenging, especially in these patients who have field effect, right? Meaning there's dysplasia over their entire aerodigestive tract. So you're never going to be able to excise their entire mouth, right? So we have to set some thresholds of when to treat and when to not treat. For grading, we want to kind of model the, almost model the cervix, although it's imperfect, mild, moderate, and severe / carcinoma in situ. Of course, the problem is that some mild dysplasias progress to carcinoma without going through that full thickness spectrum, right? And some severes do not. So it's a challenging area, but we do the best that we can. Remember, once you develop keratinizing invasive carcinoma, your prognosis is going to relate to tumor size and tumor depth, as well as lymph node status. A word on measuring depth of invasion in the oral cavity. You want to measure depth of invasion from the adjacent normal basement membrane to the deepest tumor island, right? You do not want to measure from the surface of the tumor, especially if it's exophytic. That is the tumor thickness, not the depth of invasion. And the AJCC staging system is based on depth, not thickness. Okay, so just a word of caution. This is especially important in the tongue, where measurement of depth of invasion will actually determine the need for neck dissection. So a cutoff of 3 millimeters-ish, depending on your surgeon. Below that, no neck dissection. Beyond that, neck dissection for tongue cancers. Moving into the non-keratinizing squamous cell carcinomas, the prototype here are the viral associated cancers, either of the oropharynx or the nasopharynx. I like to mention that so-called nasopharyngeal carcinoma is basically just a non-keratinizing squamous cell carcinoma of the nasopharynx, usually related to EBV. So I put these two together. Oropharynx, we have HPV-related cancers, nasopharynx, EBV-related. In the oropharynx, remember, these are generally high-risk HPV type 16, but also 18, 31, 33, 45, 52, 54, et cetera, the high-risk types. They both tend to present in middle-aged men. They both often present with cystic lymph node metastases rather than primary tumors, although certainly a primary tumor can also present. They often do not have surface dysplasia because these are tumors that arise sort of more from the deep tonsillar and adenoid crypts. And we certainly would want to evaluate for P16 and or EBV in either one. If the nasopharyngeal cancers are EBV negative, some of those are actually P16 positive in the nasopharynx, interestingly. I'm going to answer this question right now because I see it about depth of invasion. When the slides reveal the deepest part of no normal epithelium, how to measure? Yeah, that's kind of impossible. So you essentially need that surface, you need that adjacent surface normal to measure the depth of invasion. Otherwise, you have no idea whether it's exophytic or endophytic. So you absolutely need it. If you don't have adjacent normal, you basically have to say, I cannot evaluate for depth of invasion in this particular biopsy. However, the tumor measures approximately this chunk of size. Okay. Got that. All right, so the great thing, as we know about oropharyngeal cancers, is that they have a good prognosis if they are in fact HPV related. So the oropharynx is a special site, and while I talk about this, I'm actually going to launch a poll, which we're going to get to in a minute. So HPV related squamous cell carcinomas are originating from these deep tonsillar crypts where the basement membrane is discontinuous and those lymphatics are very close to the epithelium. Therefore, all HPV cancers are essentially considered invasive. So there is no concept of crypt dysplasia, crypt in situ. So if you have any sort of deep or architecturally complex involvement of an oropharynx, right, a tonsil and a base of tongue, this is invasive cancer. You don't have to go looking for single cell invasion. This is often broad-based invasion. The poll is going to be, and I'll talk about the answer in a minute, when do I order P16? When do I do P16? All new squamous cell carcinomas, all new oropharyngeal squamous cell carcinomas, lymph node mets with unknown primary, lymph node mets with known primary. So there may be multiple answers here, but you can answer that as I speak. So P16 is a surrogate marker for HPV-induced oncogenesis. As you know, it's a cell cycle protein that's upregulated by HPV viral proteins that are transcribed by our cells. It works extremely well in the oropharynx, base of tongue tonsil, for non-keratinizing carcinoma if it's a diffuse, strong, block-like, some people say, positivity in the nucleus and the cytoplasm. Outside this site, it is extremely poor predictor of HPV. You may do a confirmatory test such as in situ hybridization or PCR in the context of a positive P16 or an equivocal P16. So when do we do P16? Some of you have answered, I'm going to share the results. Some of you have answered A, most of you have answered B, some of you have answered C, and not many have answered D. So in fact, the answers include both B and C. So the College of American Pathologists, as well as the AJCC, or American Cancer Committee, have come up with the same guidelines, that being perform P16 testing on all oropharyngeal squamous cell carcinomas, base of tongue tonsil. Do not perform it on non-oropharyngeal anterior tongue, floor of mouth, larynx, don't do it. Don't provide a tumor grade or differentiation status for HPV-associated cancers, because if they're very blue and you call them basaloid and you call them high grade, that's actually not predictive of their clinical prognosis, which is very good, very well differentiated, right? So don't grade HPV cancers. And in fact, you can also perform C number 6 here for tissue specimens from patients presenting with metastatic SCC of unknown primary. A pathologist can also perform and should perform P16 IHC because, again, if it's diffuse, strong, block-like positive in that neck metastasis, it directs the surgeons to look for a tonsil base of tongue. They may do bilateral tonsillectomy. They may do base of tongue resection. So this is helpful to determine the primary and to guide treatment. Okay, so malignant appearing squamous epithelium in those neck nodes should always be considered carcinoma, metastatic, likely from the oropharynx until proven otherwise. There is really no such thing as HPV cancer arising in a branchial cleft cyst. This is a metastasis of yet unknown primary. So this is kind of a historic concept that carcinoma arising in a branchial cleft cyst is a little bit of a historic concept that really is frowned upon in most cases these days. Okay, moving on to our bony lesions of the jaws. So I put medication-related osteonecrosis, osteoradionecrosis from radiation therapy, and true acute osteomyelitis together because the histologic triad is exactly the same. Bone with no osteocytes in the lacunae, right, so osteonecrosis. Oral flora tucked in between the bones, so usually some cocci bacteria, some filamentous actinomyces, and then neutrophils. So depending on the clinical setting of true, septic osteomyelitis versus having been radiated versus being treated with bisphosphonates, that will allow you to make the diagnosis, but the the histologic picture of this triad is essentially all the same. One thing that does come up is these odontogenic cysts, so I will mention them. Here we have a picture of a cyst surrounding the crown of an unerupted molar. And so this can be one of a few things. Usually your differential diagnosis includes odontogenic keratocyst, dentigerous cyst, and cystic ameloblastoma. So dentigerous cyst basically just inflamed squamous. OKC, characteristically a very monotonous 5 to 7 cell layer thick, palisaded basal layer, corrugated cardboard surface, daughter cysts in the wall. These daughter cysts are the reason why this can't just be curetted, because these daughter cysts make the tumor keep recurring. Therefore, you have to marsupialize it, right? Open it up or do caustic therapy to treat the OKCs. In comparison, ameloblastoma, you really have to look in that surface epithelium to find the appropriate features of ameloblast, right? Which are reverse polarity, central stellate reticulum. The treatment for ameloblastoma differs depending on whether it's purely cystic with some proliferation into the lumen or multicystic solid mural involvement. So anything that's just very simple cyst can be enucleated, but anything that has any involvement of the wall with small nests, multiple cysts, or solid requires hemimandibulectomy, segmental mandibulectomy, right, where the entire segment of mandible is removed, not because these are malignant, but because these are very locally aggressive and can cause local problems. So treatment is different based on growth pattern. Not as important are these histologic variants that you may have read about. A dentigerous and a radicular cyst. So radicular cyst is generally at the root of a tooth, and dentigerous can be in a number of places around the crown of these unerupted molars. Essentially, it's the same histologically, squamous epithelium that's inflamed. So it really depends on the clinical location. Either way, if you call one dentigerous and one radicular, it's honestly, or periapical, it's not a huge deal histologically or treatment-wise, is my advice for that. So ameloblastic fibroma is another ameloblast or type of lesion, usually in the posterior mandible of kids, which is these very compressed cords of ameloblastic epithelium. You shouldn't have any exuberant epithelium, otherwise you're going to make a diagnosis of ameloblastoma instead. What ameloblastic fibroma can do, though, is transform to fibrosarcoma. So it's the stromal component that becomes malignant instead of the epithelial. Our fibroosseous lesions of the jaws include ossifying or cemento-ossifying fibroma and fibrous dysplasias. We're going to see very similar correlates in the bones later in the next lecture, but just remember that ossifying fibromas tend to be very demarcated. They tend to have variably cellular kind of whorled stroma with these variably shaped and sized either cementum or woven bone islands with osteoblast rimming. Fibrous dysplasia tends to be more poorly demarcated ground glass, right, with very much more kind of monotonous stroma, monotonous curvilinear strands of bone, no osteoblast rimming, and the bone kind of ossifies right out of the stroma. So you don't really see many osteoblasts, but you do see these little spicules, called Sharpey's fibers at the end of the bony trabeculae. Osteosarcoma of the jaws, I'm going to do a little bit of a comparison to long bone osteosarcomas because I think it's good to keep these factors in mind. So jaw osteosarcomas tend to occur more in the mandible than the maxilla, tend to occur mean age of about 30s rather than the long bones, right, which peak in teenage boys usually, as well as in elderly patients with Paget's. And so the jaws are right in the middle, no pun intended. They are more frequently chondroblastic, meaning they make chondroid matrix rather than those in the long bones, which tend to be more osteoblastic with osteoid matrix. And chemotherapy is essentially not really effective in the jaw osteosarcomas, regardless of grade. Low grade, intermediate grade, high grade. These patients don't really undergo preoperative chemo. Primary resection is crucial. So if you have something that you think is an osteosarc on biopsy of the jaw, grade is essentially irrelevant. They should take it out, and then you can grade the resection. You can certainly try to grade the biopsy, but it's much less important than it is for the long bones. Okay, moving into sinonasal lesions. So we're not going to talk about everything because there's tons of tumors that keep getting described and discovered in the sinuses. We're going to talk about what I think might be a chance to be on your boards, not these new esoteric, tiny little itsy bitsy entities. If you want to know about those, email me separately. Here are our bugs or our bug mimics. So rhinoscleroma, rhinosporidiosis, and myospherulosis. So rhinoscleroma is a Klebsiella bacteria infection that's present in foamy macrophages. Rhinosporidium is a fungus that tends to present with sporangia, these little spherules in the subepithelial stromal tissue. And myospherulosis is actually red blood cells, not an organism, but some people mistake it for organisms because of its kind of encapsulated round globoid look. These little globules are just red cells that have been packed together in patients that have been treated with some kind of petroleum product, like basically some kind of Vaseline coated gauze. So myospherulosis, not an organism, just packed red cells. We have some midline destructive diseases of the nose, kind of typified by Wegener's granulomatosis, now called granulomatosis with polyangiitis, as you know, is ANCA associated. And these patients get treated with immunosuppressive agents. So the triad here are poorly formed granulomas, vasculitis, right, and neutrophilic microabscesses. On biopsy or curettage of the nose, you are actually most likely to see the neutrophilic microabscesses rather than the other items, which can be very hard to see. So putting all pieces together, this is the perfect triad for GPA, but you may not see it all. So have a high threshold for suggesting maybe do the serum ANCA if you see anything that could be GPA in the nose. Moving into our sinonasal, formerly known as Schneiderian papillomas, you know, names change, right? Names are changing every time the WHO book comes out again. So, especially in the head and neck. So formerly Schneiderian, formerly inverted papilloma, now is just sinonasal papilloma, comma, inverted type, comma, oncocytic type, comma, exophytic type. The inverted and oncocytic occur on the lateral nasal walls, usually of males. Adults, they can have both endo and exophytic growth, characterized by, of course, these characteristic neutrophilic microabscesses in the epithelium. Carcinoma can develop in, it's thought, up to 20% of cases The classic type and the oncocytic type tend to have KRAS mutation. The fungiform or exophytic type occurs on the nasal septum and is related more often to low-risk HPV, kind of like a classic squamous papilloma. These have lower risk of developing carcinoma, probably because they're exophytic and can be excised more readily. However, they can still transform. They can all still transform. Moving into our sinonasal type adenocarcinomas, so there's non-intestinal and intestinal type. The intestinal type is the classic, right? Classic clinical pathologic correlation of an older man who's had some kind of occupational exposure to wood or leather dust or some factory, and he's got what looks like colon cancer in his nose, right? What stains like colon cancer, CK20, CDX2. So exclude that he doesn't have colon cancer and include that he has this occupational history, and this is your answer. Non-intestinal type looks kind of like a nondescript, almost cribiform carcinoma that has an opposite immunoprofile. So in this case, CK7 positive, no clinical pathologic predisposing conditions. Other mesenchymal type lesions in the sinus include nasopharyngeal angiofibroma, characteristically in adolescent males, occasionally in FAP patients, right? Whenever we have FAP, Gardner, always think about the beta-catenin Wnt signaling pathway. Yes, so these, as their name suggests, angiofibroma, vessels, and stromal fibrous tissue. The stromal fibrous tissue is positive for androgen receptor, as well as, of course, beta-catenin, both in patients with and without FAP. You can have beta-catenin nuclear expression, depending on whether there's a beta-catenin mutation or an APC gene mutation. Both manifest with nuclear beta-catenin. These are, of course, very vascular, so often they undergo embolization prior to surgery. So you may see embolic beads in the lumina. I'm sorry, I don't have a photo of that here. Other stromal neoplasms, SFT versus HPC. So this is the one area of the body where hemangioparasitoma or glomangioparasitoma, as it sometimes is called, exists pretty much only in the nose. So every other location of the body, brain, meninges, soft tissue, lung, other visceral organs, they are all effectively histologically solitary fibrous tumors, meaning they have CD34 and STAT6 positivity reflective of the NAB2 STAT6 fusion. In the sinus, there's this other entity that's very histologically similar. That's actually a perivascular myeloid neoplasm, right? So it stains for smooth muscle actin, not the CD34 or the STAT6. And it's also related to beta-catenin mutation. So it has beta-catenin in the nuclei, as you can see nicely here. The histologic difference can be subtle, especially if you have a more cellular SFT. In this case, the SFT is a little more stromal collagen rich. But usually the vessels are thin-walled and dilated on the left, and usually they're more hyalinized in the HPC, GPC on the right, but the stains should be able to differentiate. Both can be locally aggressive and present multiple recurrences. Just continue local treatment. High-grade sinonasal tumors, meaning kind of the small round blue cell tumors of the sinuses, have a wide differential diagnosis. And I've put the names of what eventually were the diagnoses down here. But you're basically going to have to do a panel of immunostains, right? There's minimal way that you're going to differentiate any of these on just H&E, except if you have a primitive neoplasm with squamoid abrupt squamous differentiation would suggest a nut. Some kind of small round blue cell neoplasm, maybe with prominent nucleoli, maybe with some brown melanin pigment, might suggest melanoma. Maybe olfactory neuroblastoma morphologically is a little bit more bland, not as many mitoses, more small and more round, and maybe you'll find some rosettes, okay? Other than that, SNUC, Ewing's, some of these things can be very, very hard to differentiate from each other. INI1 deficient carcinoma, HPV-related multiphenotypic adenoid cystic-like carcinoma, right? These are all these boutique entities that we're just learning about, would basically differentiate between the carcinomas and the non-carcinomas, differentiate between some of your sarcomas and your melanomas, of course. Your carcinomas can often be differentiated by either whether they express whether they express squamous markers or not, and then if there are any other additional genetics like NUT translocation, INI1 loss. In this case, HPV 33, P16 positivity, certainly nasopharyngeal carcinoma would have EBV. Neuroendocrine carcinomas that can happen in the sinus, of course, should have your neuroendocrine markers, but I'll provide this table for you. Look it over at your time. Okay, moving into the larynx. All right, we have 20 more minutes, I think. So remember I'm outlining here for you the supraglottis, the glottis, and the infraglottis because carcinomas of the larynx are staged dependent on their primary subsite, and the supraglottic, glottic, and infraglottic staging systems are slightly different. So the supraglottis is anything from the epiglottis to the ventricle, right? The ventricle is the space between the false chord and the true chord. The true glottis starts again at the ventricle, includes the true chord, and goes down to about 1 centimeter below the true chord / ventricle. And then the infraglottis is everything below, all the way to the inferior border of the cricoid where the trachea starts. All right, so those are your compartments. We're going to go over essentially the most common tumors of the larynx: papilloma, carcinoma, carcinoid, chondrosarc in each of the categories. So squamous papilloma, we know, is related to low-risk HPV virus, right, 6 and 11. They can happen as solitary sporadic lesions, usually in adults, but once they are in kids and they are multiple, right, you want to think about recurrent respiratory papillomatosis or juvenile respiratory papillomatosis, where these kids acquire it in the birth canal of the mother. These can develop into squamous cell carcinomas, more so with radiation exposure or smoking, or in the deep tree of the lung, where you have a hard time removing the papillomas. Squamous cell carcinomas in the U.S. are most common in the glottis, of course related to tobacco alcohol exposures. Prognosis and treatment is, of course, stage dependent, meaning how far has it spread locally? Is it in the tracheal cartilages? Is it in the strap muscles? Is it out and about, or is it restricted to the larynx? Histologic grading, like most squamous cell carcinomas of the head and neck, has effectively limited impact, and we do not grade at the U of C our squamous cell carcinomas. We say keratinizing or non. Neuroendocrine tumors of the larynx, atypical carcinoid is the most common histologic pattern, or the intermediate grade neuroendocrine neoplasm, right? So carcinoid low, atypical, intermediate, high grade neuroendocrine carcinoma / small cell carcinoma, basically graded just like that in the lung based on mitoses and nucleoli and pleomorphism. These can metastasize at any morphologic type, carcinoid or atypical, and mostly these are insensitive to chemoradiation, therefore these undergo surgical treatment. The most common sarcoma of the larynx is chondrosarc. These tend to be grade 1 to grade 2. Any cartilaginous tumor greater than 2 centimeters with atypia should essentially be regarded as a chondrosarc, most common in the cricoid cartilage, treated with resection. All right, a few things in the ear. This is going to be jugulotympanic paraganglioma, most common tumor of middle ear. These used to be called glomus tympanicum. Don't get these confused with the glomus tumors of the digits, which we'll talk about in the next lecture. These are basically paragangliomas of the ear with your Zellballen, with your S100 subtentacular cells. In general, these days for paragangliomas, we are screening them with SDHB immunostain to screen for a possible SDH syndrome, because the only good predictor of behavior in paragangliomas, i.e. whether they're going to metastasize, is if the patient has a germline SDH mutation. Otherwise, there's no good histologic criteria or scoring system to predict malignancy in these, right? So in the head and neck, we're mostly dealing with carotid body, followed by middle ear. But any loss or significant decrease in expression as seen here in SDH, patients should undergo germline screening. Second common tumor of the middle ear are middle ear adenomas, keratin expressing, whereas of course paragangliomas would be keratin negative. Papillary endolymphatic sac tumors you mostly are going to hear about in association with von Hippel-Lindau, again locally aggressive in the mastoid, but not really considered malignant or metastatic. All right, moving into the glands. So we're going to get salivary and then thyroid, my favorite. So starting with salivary. Carcinomas of the salivary gland are rare. We know that most salivary gland tumors are benign, right? Pleomorphic adenoma, pleomorphic adenoma, pleomorphic adenoma. And mostly you're going to be dealing with tumors of the parotid. However, if you're in the sublingual, this is actually the site of the highest rate of salivary malignancies. We're dealing with pleomorphic adenoma followed by Warthin for benign. And for malignant, we're dealing with mucoep, remember, both in adults and kids, followed by adenoid cystic and perhaps also acinic. One thing I always want you to remember for necrotizing sialometaplasia is this is a histologic mimic of squamous cell carcinoma, which is generally somewhat ugly in appearance, but it retains the ductal-lobular architectural configuration. It can present as a solitary ulcer on the palate, but it can also just present sporadically in patients who've had prior surgery or radiation. And really, you want to look for lumina with debris in the duct. Lumen, you want to look for some associated goblet cells, and you want to look for that retention of ductal-lobular architecture. I've given you I will give you two different charts for salivary. One is the benign tumors with the malignant counterparts, and the second chart we're going to see is just those that are malignant with no benign counterpart. I've also listed the number of cell types because that always is helpful for me in identifying salivary gland neoplasms. How many cell types does it have, and what are the potential genetic aberrations? I'm not going to go over the gene aberrations, they're just listed here for you. So starting with PA, y'all know what a PA looks like, but I want to tell you what it can do. So especially after incomplete excision, it can recur. How does it recur? It recurs as these like little multiple small buckshot nodules in the stroma. It doesn't recur as a nice like solitary, oh, there's another PA. No, boom, boom, boom. So when you see that, that is inevitably a recurrent pleomorphic adenoma, and these can be extremely hard to excise. You may see some tyrosine crystals in the stroma. That's just an anecdotal fun finding. Of course, pleomorphic adenomas can so-called metastasize in a benign fashion, meaning that they are morphologically bland, but can go to sites outside the neck, including lung, etc. They can transform to a high-grade carcinoma, carcinoma X, that usually starts as an in situ proliferation within the ductules of the pleomorphic adenoma, where they develop nuclear atypia and mitoses, and then they invade outside of the main tumor nodule into the adjacent stroma. And the morphology of the invasive cancer can essentially be anything. It's often salivary duct. It can sometimes be myoepithelial. It can sometimes be squamous, and so on. Moving on to our second benign tumor, which is Warthin. Is it really a tumor? Is it really a reactive change? No one really knows. Often in smokers, often bilateral, right? So maybe a reactive change. Often undergoes pain if it infarcts. Remember, these are PET avid, so they can light up when patients are getting PET scans for other cancers. And, oh, patients got colon cancer. There's something in their parotid. It's probably a Warthin, especially if they were a smoker. Remember your double layer of oncocytes with abundant lymphoid stroma. Okay, basal cell adenoma, basal cell adenocarcinoma can resemble dermal cylindromas with these very blue, large nests with peripheral palisading. Characteristically, these eosinophilic globules or eosinophilic basement membrane material. Sometimes the structures can be more ductal and lobular versus large and solid. Beta-catenin as well as LEF1 immunostains have been occasionally helpful in identifying basal cell adenoma, adenocarcinoma if present in the nucleus, generally of the peripherally located myoepithelial cell component. Pure myoepithelial neoplasms of the salivary glands really should not have any ductal components. I think pure myoepitheliomas are very rare. Mostly they're cellular pleomorphic adenomas, but myoepithelial carcinomas can occur. They, as I said, can transform from PA. They can arise de novo. And if they are in clear cell morphology, they often have EWSR rearrangement. I see your question about basal cell adenoma versus adenocarcinoma. Invasion. Adenocarcinomas of basal cell morphology can be very low grade. So really it's a diagnosis of a circumscribed edge versus an invasive border to differentiate the two. Okay, now your malignant tumors only. So these have no essential benign counterparts. Just to repeat, for most tumors to differentiate the benign from the malignant counterpart, that's going to be the presence of invasion. The most important thing to diagnose carcinomas in salivary gland is invasion. But some tumors, right, even if they can be somewhat well circumscribed, like a low-grade acidic or like a low-grade secretory, sometimes those are very well circumscribed, but they don't have a benign counterpart, so inevitably they are a carcinoma. Again, genes are listed here. So muco-ep has 3 cell types, it's 10 minutes, and 3 grades. Mucinous, intermediate, and squamoid cells can be solid, can be cystic. I advocate for the Brandwein grading system, even though it sometimes overgrades tumors. If it's Brandwein truly high grade, these are the ones I worry about for having high grade behavior. If it's Brandwein lower intermediate grade, those tend to have low grade clinical behavior. And I mention that mostly because sometimes clinicians don't know what to do with intermediate grade muco-eps, mostly treat them as low. All right, adenoid cystic, 2 cell types, right, epithelial, myoepithelial, and 3 grades depending on whether they're mostly tubular, cribiform, or solid. High frequency of perineural invasion and facial nerve pain, classic cribiform or sieve-like or Swiss cheese architecture. The 2 cell types that you see are epithelial, highlighted by C-KIT, and myoepithelial, highlighted by P63. Remember, it's the myoepithelial component that secretes that basement membrane mucinous material. Acinic cell carcinoma recapitulates the serous acinar cells. You can do PAS with diastase to show your zymogen granules. Both acinic cell and adenoid cystic can transform or so-called de-differentiate to a very high-grade malignant neoplasm that essentially is indistinguishable from any other salivary carcinoma. You'd have to look for the low-grade component in the background. This is a high-grade cancer with prominent nucleoli, lots of mitoses, no architecture, solid growth. So just look for that low-grade component in the background. Polymorphous should be differentiated from adenoid cystic based on the absence of 2 cell types. So this is the most common, so polymorphous, adenoid cystic, and sometimes a very cellular pleomorphic adenoma are on your differential. Polymorphous is the most commonly located in the palate, but is not the most common tumor in the palate, right? So if you're in the palate, don't think automatically it's a polymorphous. You still need to make sure it's not a PA, okay? The way you can do that is by proving that there is no P40 positive myoepithelial cell layer, right? So polymorphous is a single cell type, unlike both adenoid cystic and pleomorphic adenoma. But the morphologic patterns can be overlapping, right? Cribiform, tubular, ductular, solid, glomeruloid, all of it, okay? Secretory carcinoma was defined based on its sister in the breast by ETV6 NTRK3 rearrangement, by microcystic and secretory architectural patterns, by diffuse strong positivity for S100 as well as mammoglobin. So these are generally low grade, but can undergo high grade transformation as well. Salivary duct is on its own considered high grade, essentially, in most cases. These resemble high grade DCIS of breasts, tend to be androgen receptor and HER2 positive, but ERPR negative. So if you have a salivary gland tumor that is ERPR positive, it's a breast cancer, okay? It's not a salivary cancer. Epimyoep sometimes shows up on the boards with its characteristic double-layered ducts. Sometimes you have these ducts punctuating a myoepithelial cell background. The myoepithelial cells in the background tend to have very clear cytoplasm as seen here. Okay, thyroid, last 5 minutes or so. Here's a comparison of all of your thyroididities, essentially your non-neoplastic thyroid. Hashimoto's, remember lymphoid follicles with germinal centers, and oncocytic metaplasia of your background follicles. Granulomatous or de Quervain's thyroiditis, multiple giant cell granulomas, often after a viral respiratory infection. Fibrosing or Rydell thyroiditis, that characteristic rock hard, is thought to be potentially an IgG4 related sclerosing disease. So sometimes we do IgG4 on tissue or in serum. Graves' disease is related to some of your HLA subtypes, just like Hashimoto's, and has papillary hyperplasia with scalloping of colloid, the characteristic features The other rare entity I will mention is dyshormonogenic goiter, which is a genetic defect in thyroid hormone production, function, excretion, secretion, reception. So any one of a number of mutations cause these multiple nodules that can look like a very cellular variant of Graves', but the background is also extremely, extremely cellular. So this is rare, but think about this in kids with multiple nodules. The other genetic thing you might want to think about in patients with multiple thyroid nodules is what? Like a Cowden syndrome, like a P10 mutation syndrome can result with multiple highly cellular nodules in thyroid. Okay, so moving into tumors. So indeterminate malignant potential is hyalinizing trabecular tumor, which is of course of follicular epithelial cells, very well circumscribed, arranged in trabecular cords, but with characteristic nuclear features of PTC. Grooves, wrinkles, inclusions, right? So the trabeculae might make you think of like a paraganglioma, but the nuclei make you think of PTC. So these can have RET PTC rearrangements. Most of them do not have BRAF or RAS mutations. They behave extremely indolently. Is de Quervain's the same as subacute? I think yes, sometimes it's called subacute in some of the books, yeah. Okay, so that's hyalinizing trabecular tumor. Remember that tumors of follicular epithelial cells, such as HTT, stain for all thyroid markers, right? TTF1, PAX8, thyroglobulin. Well-differentiated thyroid carcinomas include papillary and follicular. Remember, thyroid disease is mostly a disease of women. Young, old, middle-aged, all of it. Yes, men can have thyroid disease. It's just overall more common in women, whether it's benign or malignant. So here's a comparison of papillary versus follicular. Certainly papillary is far more common, mostly related to BRAF mutations, sometimes RET PTC rearrangements, whereas follicular is genetically exclusive, RAS mutations and PAX8 PPAR gamma rearrangements. Usually PTC spreads lymphatically, right to lymph nodes. FTC spreads via blood vessels to bone and lung, and PTC survival is very good. FTC survival, once it's in vessels and out of the box, it tends to be a little bit more poor survival. So sorry, I see your question. P10 associated cellular nodules can be benign or malignant. Usually it's follicular adenoma, then it's follicular carcinoma, and sometimes it's papillary carcinoma. So it can be anything. You just have to use your standard morphologic criteria. All right, variants of PTC are shown here. Tall cell, columnar cell, diffuse sclerosing, and cribriform morular. So tall and columnar are the ones that are tall or columnar, right? But tall cell tends to be more pink on low power with long papillae. Columnar cell tends to be more blue with the endometrioid appearing look. Aggressivity kind of depends on the extent of invasion, extrathyroidal extension, etc. Both diffuse sclerosing and cribriform morular have squamous morules. Remember, diffuse sclerosing is usually of younger females, can involve the whole lobe or in fact multiple foci throughout both lobes with lots of lymph node mets. Cribriform morular should really have a cribriform growth pattern, tends to have beta-catenin positivity in the nucleus, either in sporadic or syndromic patients. So again, if you see a cribriform morular, you see beta-catenin in the nucleus, screen the patient for FAP. They may have FAP, they may not, but you should still see beta-catenin because whether it's somatic or germline. Okay, so remember follicular variant of papillary thyroid carcinoma is the tall cell and columnar cell switched. No, it's just the columnar cell it's just a coloration appearance. I can send you better pictures later if you want, but notice the vacuoles in the columnar cell. That's like super characteristic of columnar cell. And the very, very dense cytoplasm of tall cell, that's very characteristic of tall cell. So even though the pictures are imperfect, they're not swapped. They're just imperfect pictures. I'm sorry, I'm an imperfect person. Okay, so follicular variant of papillary thyroid carcinoma, circumscribed, is now NIFT-P, right? So NIFT-P, non-invasive follicular thyroid neoplasm with papillary-like nuclear features. I have 1 minute. The criteria were proposed in 2016 and revised in 2018. I'm going to let you read it over yourself. But essentially, the best advice I can give you for a NIFT-P is It is basically something that is otherwise a follicular adenoma, but it has nuclei that highly resemble papillary with clearing, with grooves, with wrinkling, okay? If you see a true pseudo-inclusion in this, you might want to think twice about it being a NIFT-P, but basically think follicular adenoma with nuclear changes, okay? It is genetically a follicular adenoma with usually RAS mutations. When it invades like a follicular carcinoma with capsular and vascular invasion and travels to brain, lung, bone, etc., rather than lymph nodes. The last thyroid is poorly and undiff. So this is now, you're no longer in your well-diff category. You're getting biologically and histologically worse. So the Turin criteria for poorly differentiated carcinoma, solid or trabecular growth, absence of PTC nuclei, and presence of at least one of the following: racinoid nuclei, mitoses 3 or more, and necrosis. These retain the morphology of follicular cells and the immunoprofile of follicular cells. Anaplastic no longer looks like thyroid, right? Looks like sarcoma, looks like undifferentiated carcinoma, and it starts to lose markers. First loses thyroglobulin, you're never gonna see it. It then loses TTF1, and then lastly, it'll lose PAX8. So if you have any chance of it being anaplastic, try PAX8. The other thing you could try is, if this arose from a papillary carcinoma, you might be able to find BRAF mutation. If it arose from a follicular, you might be able to find RAS. Here's more examples of poorly diff, because people tend to forget about this sometimes because it looks like, oh, it's just like a solid follicular carcinoma. Yes, it looks like a solid follicular carcinoma. When you see that, start counting mitoses and start looking for necrosis, because then you go poorly diff and this patient has a worse prognosis. All right, 10:46. I'm very sorry I'm going over, but you got me until 11:45, so I'm gonna go over from thyroid. Sorry, guys. All right. So medullary is your last non-follicular cell carcinoma, right? This is a cancer of C cells, can be familial, can be sporadic. Actually, most are sporadic. About 75% of medullaries are sporadic in all age groups. In kids, they're familial, essentially. Unifocal versus multifocal, you know the characteristic buzzword of, amyloid with apple green birefringence, characteristic nuclear salt and pepper with granular cytoplasm of neuroendocrine neoplasm, calcitonin positivity. These patients should be screened for RET mutation. If there is a RET mutation in the tumor, then they should go get screened for a RET mutation in their germline. Okay, the one thing I will say about parathyroid, and then I'm done with this lecture, is 3 things you want to think about in parathyroid, other than your run-of-the-mill, it's an adenoma, it's hyperplasia, whatever. You want to think about atypical adenomas, you want to think about parathyroid carcinomas, and so-called parathyromatosis. So parathyromatosis is thought to be a diffuse seeding of parathyroid tissue in the neck after prior surgery, kind of like a recurrent pleomorphic adenoma. Same concept, these small nodules in tissue that are very circumscribed, otherwise totally bland, all right? Atypical adenoma starts to be a solitary large nodule that has a lot of fibrous bands, maybe a little bit of a pushing out into the world. You're like, ooh, was that cancer? Cancer of parathyroid is very hard to diagnose unless you have things like necrosis, and think vascular or perineural invasion. Occasionally you'll get prominent nucleoli, but not needed. Sometimes you may get loss of CDC73 gene, which manifests as loss of parafibromin on IHC. So this is the gene, CDC73 is the gene, parafibromin is the protein product. But carcinoma can be extremely, extremely hard to diagnose. If you're uncertain, atypical adenoma is fine. Treatment is the same. There is absolutely no treatment for either of these except just continued local resection. Okay, that was this lecture. Are there any unresolved questions?
That was super fast and super awesome. She's going to get a vocal nodule tomorrow, for sure. So go up and read up on that too, as to how a vocal nodule looks on histology. But Dr.
Oh yeah, I didn't even talk about that, did I?
No, you're doing great. Do you want to take a 2-minute stretch break before you go on to the next one?
No.
You are going awesome?
Yeah.
All right.
Bone and soft tissue is frickin' long, so I can't afford a break. Can
it's
you
high intensity for you, not high intensity for our attendees.
right.
All right. I am hoping you can see my screen. Okay. All right. Again, I pre-apologize how fast this is going to go, but this is ridiculous. So, the good thing is, I think, like, the questions they're going to ask you on the boards about bone and soft tissue are probably not extremely numerous and potentially manageable. All right, that's all I have to say. So we're going to start with bone. I like to think about bone as how old is the person, where is it in the body, where is it in the particular bone, and then do you think it's benign or malignant? And for clinical practitioners, you, of course, don't ever want to overdiagnose something that is benign and call it malignant in the bone on, I said the wrong thing. You don't want to underdiagnose something and call it benign when it's really malignant. So if you call something benign on frozen, they might potentially curette that bone, pack it, and contaminate that person's leg. If you call something malignant or I don't know, they're going to stop, be cautious, close, and wait, right? So always be extra cautious on bone unless you're certain it's benign, and always use radiology, the surgeon's impression, together with your histologic diagnosis, because you should never diagnose any bone lesion without radiographic correlate, ever. Okay, so here's a list of the most common tumors, just statistically, because sometimes the boards like to ask about statistics, right? Okay, so for each of the bone lesions, I've provided a small snippet on the top in a box and some extra details in a smaller font on the bottom. So because we're gonna go fast, I'm mostly just gonna talk about the middle box with the big text, and you can read the rest on your own. So most common primary bone tumor is osteochondroma, sometimes called exostosis, right? So this is a neoplasm of cartilage that induces bone growth underneath it into this cauliflower-like stalk, and that bone below it is continuous with the marrow of the bone in which it arises. These tend to arise from endochondrally ossified bones rather than intramembranous bones, and it's thought that cartilaginous plate has a disruption and grows off into this cauliflower stalk. Of course, if it's multiple hereditary exostosis, that's where you risk having chondrosarcomatous transformation. The secondary chondrosarcomatous transformation is now an exophytic, exuberant proliferation of cartilage on like cauliflower-like, rather than just this nice thin little cartilaginous cap, right? So always measure the thickness of that cartilaginous cap, because that's what the clinicians are going to worry about. This image on the right is chondrosarc. Okay, the other cartilaginous thing of bone is BPOP, bizarre parosteal osteochondromatous proliferation, sometimes called Nora's lesion, subungual exostosis. This is a reactive thing, not really a tumor, on the small phalanges, that is a hybrid of kind of disorganized cartilage, disorganized bone, and disorganized fibrous tissue, in contrast to the osteochondroma, right, which is very structurally organized. Okay. Enchondroma is, of course, your benign intramedullary growth of cartilage that can happen in long bones, that can happen in small bones of the hands and feet. It pushes the bone aside, so it has peripheral ossification without actual entrapment of lamellar bone. In the digits, these can be much more highly cellular, so don't overdiagnose these necessarily as chondrosarc in the digits. Both benign and malignant cartilaginous neoplasms can have IDH1 and 2 mutations, so that will tell you that it's cartilage, chondrosarc, rather than chondroblastic osteosarc, but it won't tell you whether it's benign or malignant. So IDH, cartilage, not benign or malignant. Once you're dealing with a malignant chondrosarc, you're dealing with something that now entraps your pre-existing trabecular bone, that has more of a more of a myxoid appearance rather than a hyaline stromal appearance. Can be of varying grades from 1 to 2 to 3 to dedifferentiated, which is basically high-grade spindle cell sarcoma next to low-grade cartilaginous sarcoma. Clear cell chondrosarc tends to occur in the epiphysis of the adults in long bones,
which is basically islands of some kind of obvious cartilaginous differentiation next to these clear cells that you might otherwise think about, RCC or some other clear cell neoplasm. Versus mesenchymal chondrosarc, which is when you think mesenchymal, think highly cellular spindle cell. So again, highly cellular spindle cell interposed with some more obvious hyalinoid or myxoid cartilage. This tends to be in the jaws of younger teens. Very, very, very poor prognosis. Fusion is listed here, which is Hay and COA2, so that can be helpful for diagnosis of these odd, rare things. Chondroblastoma is your characteristic epiphyseal, right? Epiphyseal tumor in the long bone. So this is one of those rare tumors that occurs at the very, very tip of the bone, but can cross the growth plate. Giant cells, of course, plus mononuclear cells with wrinkled, curved nuclei with this classic chicken wire calcification in the background. That's opposed to chondromyxoid fibroma, which still has some giant cells, still has some mononuclear cells, but is this very lobulated, more paucicellular myxoid cartilaginous thing where your hypercellularity really only occurs at the periphery of these lobules. NOF, non-ossifying fibroma, I like to think of as the dermatofibroma or fibrous histiocytoma equivalent of bone. It has this kind of foamy or a bubbly appearance on radiology characteristic, this storiform or whorled growth pattern, just like a fibrous histiocytoma, with some associated giant cells, and basically non-ossifying fibroma, correct, no bone, okay, or minimal bone. Okay. Your differential diagnosis of a giant cell rich lesion, of course, might include a true giant cell tumor of bone, which can be very locally aggressive, very expansile, even erosive of the cortex. This tends to be around the knee in young adults, right? So basically femur, tibia. These are evenly spaced giant cells with evenly spaced mononuclear cells, where the nuclei of the mononuclear cells appear very similar to the nuclei of the giant cells. This is in contrast to chondroblastoma, right, where the nuclei of the chondroblastoma are kind of curved and wrinkly, and the nuclei of giant cell tumor are open with nucleoli, all right? When these can have histone H3.3 mutations, so that can be helpful for your diagnosis. Sometimes these are treated with denosumab, which is a rank inhibitor. What it does is it forces maturation into bone. So post denosumab, you're going to get loss of giant cells and presence of bone and fibrous tissue. Don't misdiagnose this for some other sarcoma. This is a treated giant cell tumor. Your next giant cell rich, of course, differential is ABC. ABC can be cystic, ABC can be solid. Characteristic fluid levels on MRI, again, around the knees. So same location as before. You might have giant cells that jump into the void like lemmings, right? But you may just have a solid ABC. A solid ABC has some spindled stroma, some pink osteoid, some blue bone, some giant cells, but always, whether solid or cystic, should have USP6 gene rearrangement. If it's secondary ABC change in a pre-existing giant cell tumor, et cetera, it should not have the USP6 rearrangement. That's only for primary ABCs, right? Another differential diagnosis with a cystic lesion is telangiectatic osteosarc. Looks very cystic and potentially ABC-like on low power, but on high power in the wall, you're gonna see high-grade malignancy, right? You're not gonna see nice, cute little spindle cells. You're gonna see these ugly, large, giant, cells with hyperchromatic nuclei, prominent nucleoli, lots of mitoses. You'll probably, hopefully see some osteoid because it is an osteosarc, okay? But again, same clinical, kids around the knee, okay? Other giant cell rich lesions include brown tumor of hyperparathyroidism. So don't forget this in your differential diagnosis, which is extremely histologically similar to giant cell reparative granuloma that tends to happen in the jaws. These are lobulated with mononuclear cells and osteoclast cells and spindle cells, and this very kind of vascular extravasated red cell appearance in the background, almost like, kind of maybe like nodular fasciitis, right, with these extravasated red cells. So think about this if the clinical situation is appropriate. Okay, moving into our bone forming lesions. So solid radiodense lesion, usually in the craniofacial bones. is osteoma, right? Sometimes associated with Gardner syndrome, especially if multiple, sometimes sporadic if solitary. Osteoid osteoma, right? Your characteristic, I'm a teenager with night pain, relieved by NSAIDs. I'm small, I'm in the cortex of a long bone. And what they do is they go in and radio frequency ablate and it's over. So this, you may or may not actually see histologically because after they ablate it, it's out and it's done. And you're not going to get much tissue, but osteoid, right, with osteoblast, osteoid or woven bone with osteoblast rimming and this kind of fibrocellular background. Very similar to osteoblastoma, also a young adult, but really not really relief with NSAIDs, not really that same night pain, and larger, okay? Often also in the posterior elements of the spine as seen here. Similar thing of woven bone with osteoblast rimming, but occasionally the osteoblasts tend to be a little more plump or epithelioid, which may predict a little more aggressive behavior, but this is osteoblastoma. Okay, osteofibrous dysplasia to me kind of looks like ossifying fibroma of the mandible. So it's got this storiform fibrous tissue in the background. It's got woven bone with osteoblast rimming. The characteristic appearance of this is in the anterior tibial cortex of a young male. So there are two possible things you could be dealing with in the anterior tibial cortex. Osteofibrous dysplasia, okay, or adamantinoma. What does adamantinoma look like? Sometimes it looks like a meloblastoma of the jaws, okay? Sometimes it looks like these tiny little compressed islands of epithelium in a background of what's otherwise an osteofibrous dysplasia, okay? So be careful. If you want, do a keratin stain on these to show if these little islands highlight. If they do, this is an ameloblastoma, and now this has a little bit of a more aggressive behavior than if those epithelial islands weren't there. Sometimes it's just obvious, looking like an ameloblastoma of jaw. Okay, we already talked about fibrous dysplasia in the head and neck. It's the same in other bones histologically. It often occurs in the ribs as well. Remember, GNAS mutation can occur both in syndromic cases as well as just polyostotic fibrous dysplasias. We're done with this. Okay. But your differential diagnosis, of course, of a fibrous dysplasia is going to have to be a low-grade intramedullary osteosarcoma, which has cellular fibrous tissue, has these long bony trabeculae. What's different is the nuclear atypia of these background spindle cells, right? This looks hyperchromatic and enlarged. This looks like a mitotic figure, and there's MDM2 amplification. So if you ever don't know, do the MDM2 IHC, or if the tissue is appropriately decalcified in EDTA rather than HCl, do the MDM2 FISH and you should find amplification if your differential diagnosis is with a fibrous dysplasia within the medullary cavity of the bone. Versus conventional osteosarc, which shouldn't be high grade, right? You should have crispy kind of osteoid. You should have nice, more soft, small osteoid with these malignant cells being entrapped by the pink osteoid. Enlarged, hyperchromatic, etc. Some places use SATB2 to differentiate true osteoblastic cells from mimics like malignant cells in collagen, but a lot of papers have shown that SATB2 is actually not helpful and can stain a lot of things, so we don't really actually use it. Remember, 2 peaks in young males, usually in around the knee, and then second peak in adults, often with other diseases, Paget's, etc. Okay. Here's your characteristic Codman's triangle of osteosarc, which is an elevation of the periosteum off the bone as the osteosarc is pushing it out, right? So this is Codman's triangle in life. This is Codman's triangle in a shadow in radiology, right? Okay. Now we move into the surface osteosarcomas. So those are par or periosteal. Those occur around the distal femur, distal femoral diaphysis, also often of young kids, but rather than being in the marrow, they're sort of stuck on the bone, okay? They can either be more fibroblast rich, as in parosteal, or more cartilaginous rich, as in periosteal. Hey, the good thing about parosteal is that it looks like fibrous dysplasia, maybe. It looks also like a low-grade intramedullary osteosarc, and it also has MDM2 amplification. So I like to keep this in mind for these low-grade fibroosseous lesions of bone. Always think about doing MDM2. These both get locally resected rather than having neoadjuvant chemo. If there's any suggestion that there's an intermediate or a potentially high-grade component to one of these, they may undergo neoadjuvant, but mostly this is a surgical disease. Again, just a reminder that your low-grade fibroblastic surface osteosarc in young people with MDM2 amplification is parosteal. Your low to intermediate grade chondroblastic in young people without MDM2 is periosteal, okay? I didn't know really where to put this, so here it is. Langerhans histiocytosis, eosinophilic granuloma, histiocytosis X is, of course, your histiocytic intramedullary disease, mostly of kids. Can be single or multiple bones. You know the drill, right? Your folded or kidney bean-shaped nuclei, your background EOs, your CD1A, your Langerin, your S100, your BRAF, don't forget these tend to be BRAF mutated, and your Burbeck granules on electron microscopy if the boards still like to test on those, I don't know. Your other intramedullary neoplasm of kids, small round blue cell tumor, is going to be Ewing's. You know, of course, this pops up in the head and neck, this pops up in the soft tissue, this pops up in the bone. We have to think about it anywhere we see a small round blue cell tumor. Remember, EWSR Fly1 is your most common translocation partner. EWSR ERG is your second most common translocation partner. I don't know, I can't remember if I had, I may have in the soft tissue lecture. If I don't, you can ask me about it. The Ewing's-like sarcomas, right, like the chick ducts and the B core. If I don't mention it in this lecture, at the end, I'll do a little 2 words on it. Okay, does anybody have any questions on bone now before I move into soft tissue? I don't see anything in the chat, in the Q&A. Okay, I know, it's overwhelming. It's overwhelming for all of us, me included. Okay, so for bone, right, we talked about age, location, radiology. For soft tissue, we can think about lineage of differentiation, we can think about histologic pattern, but really in the end, we have to combine both. And so, is there a Ewing-like adamantinoma that does show CD99 positivity? There's an adamantinoma-like Ewing sarcoma. A lot of things show CD99 positivity. Yes, which is why it's not a super specific marker. That's why the genetics is actually most important. So even something like, what's the word I'm looking for? SFT can show CD99, so it is quite less specific, but yes. Do you use BRAF for LCH? Sometimes really you're gonna wanna start with the more broad things like CD100, S100, CD1A Langerin, because those are gonna be more sensitive, and the BRAF isn't necessary. If the heme person is on there and wants to correct me, I don't think all Langerhans are BRAF positive, but really most should be S100 CD1A Langerin expressing. Yeah, most are fine. Most are, but perhaps not all. We have BRAF IHC, which I think is amazing. I use it for thyroid. We use it for Langerhans. We use it for other histiocyte disorders. We use it, of course, for melanoma. Okay. I think we're done with these. Okay. So moving back into soft tissue. So I recommend the Hornick book for histologic pattern. I recommend the WHO and the Enzinger and Weiss book for more of a lineage of differentiation approach. One thing I want to stick here in the corner is, sometimes the boards ask about tumors that metastasize to lymph nodes. Those are going to be things like angiosarc, embryonal rhabdo, epithelioid sarc, clear cell sarc. If they ask you which one of these is more common than the other, I don't even know the answer to that. So just pick one. Okay, just pick one. Give up on it. I'm just kidding. That was rude of me to say. Okay, maybe you can find me the answer of which one is the most common. All right, so first we're going to start with some tumors of lineages of differentiation, and then we're going to move on to a pattern-based approach. So first we'll start with fat. Remember, fat can be benign lipoma, fat can be an atypical lipoma, a lipoblastoma, and a liposarcomas. So you got to start with what a fat cell looks like. So a normal fat cell is large with a nucleus at the side. Lipoblasts can be of varying sizes, but what they have in common is the nucleus is pushed aside and indented by the vacuole. Whether it be a solitary fat vacuole or multiple vacuoles, they always indent the nucleus. Brown fat, the nucleus is not indented by the vacuoles, and fat necrosis can be scary because it can look all weird and wavy and the cytoplasm is kind of falling out, but you're gonna wanna see these nice little kind of foamy histiocytes around the sides of the fat necrosis. Okay, so your benign adipocytic tumors are listed here, ranging of course from a lipoma, purely fat, to a hibernoma, purely brown fat, or mixed brown fat and regular fat, to an angiolipoma, right, forearm, multiple, young, small little capillary-like vessels with fibrin thrombi, to spinocellular pleomorphic lipoma, characteristically the posterior neck, shoulder, back of middle-aged men with what? Ropey collagen, bland spindle cells, sometimes hyperchromatic or floret cells if it's on the spectrum towards pleomorphic, and CD34 positivity, and loss of RB, right? Loss of retinoblastoma. Lastly, lipoblastoma, you're going to think about in kids. It has to be present essentially at the time of birth. Should see some myxoid stroma with lipoblasts. If it matures, you may lose the lipoblast, you may lose the myxoid stroma, but you may retain some lobulations of that lesion. The genetics are listed here for you below. We don't often use the genetics in fatty lesions, but we can if we need to. Or I should say, we don't often use the genetics in benign fatty lesions. I've highlighted spindle cell pleomorphic lipoma because this often comes up on the boards so frequently. Remember it. Okay. Moving into the malignant adipocyte tumors where we do use genetics. We use genetics to characterize these into atypical lipomatous tumor / well-diff liposarc, which transforms to D-diff, myxoid liposarc, which transforms to round cell, and then pleomorphic, which is just a thing in and of its own. Remember that ALT is when this tumor occurs in the extremities, well-diff is when it occurs in the retroperitoneum, and D-diff can happen in either as a transformative event. Genetics are defined by chromosome 12 MDM2 amplification on the left, DDIT3 FUS rearrangement in the middle, and essentially non-specific complex karyotype in pleomorphic. So just as a reminder, you're going to be dealing with, usually for ALT well-diff, a fatty lesion with atypical or hyperchromatic stromal or spindle cells. There are variants of well-diff, right? That's lipoma-like, sclerosing, inflammatory. But once you get to D-diff, you're often just at a high-grade, very ugly sarcoma with spindle cell differentiation in which your MDM2 positivity in the nucleus and your MDM2 amplification are going to be extremely helpful. This is manifest on cytogenetics as a ring, or sometimes called giant marker or giant rod chromosome, like a very long, large chromosome 12. This is thought to be less aggressive than other high-grade sarcomas in the extremities. So if you give someone a D-diff liposarc, it's probably going to recur and to a lower frequency metastasize. Always remember that well-diff liposarc can have myxoid-like areas, and D-diff liposarc can have pleomorphic-like areas. So if you're ever concerned about which of the fatty sarcomas it is, do the genetics, okay? If you are in the retroperitoneum, it is essentially, effectively, always this, okay? Regardless of what it looks like. It can look myxoid in the retroperitoneum and not be truly myxoid liposarc. It can look pleomorphic in the retroperitoneum and not be truly pleomorphic liposarc. If there's one thing I want you to remember of all this, please remember that retroperitoneal specificity of this chromosome 12, MDM2, well-diff, D-diff spectrum. Okay. If you're in the extremity, usually of a younger adult, you may be dealing with a myxoid, right? Chicken wire vasculature, myxoid stroma, little tiny bland lipoblasts that are either multivacuolated or signet ring. Once you start to get increasing cellularity with these round cells with prominent nucleoli, that's when you're dealing with round cell. 5% round cell is the cutoff for theoretically difference in behavior. DDIT3 FUS. If you see something like this in the retroperitoneum, again, remember, it is either a metastasis of a peripheral tumor or a myxoid variant of well-diff. As long as you have MDM2 that trumps histology, yes, absolutely. MDM2 positive nucleus with MDM2 amplification is trumping of everything. If you're in a fatty tumor, because you can have MDM2 positivity in the nucleus of some like muscular tumors that don't have MDM2 amplification. There you kind of have to be careful, but in a fatty tumor, yes. Okay. Pleomorphic here it is. So here's pleomorphic liposarc. If you see this in an elderly person on the extremities and there is no other well-diff component and you do the MDM2 and it's negative, yes, it's pleomorphic liposarc. Pleomorphic lipoblasts, very ugly, very aggressive behavior. If you see this and you do the MDM2 and it's amplified, it's D-diff liposarc. Now moving into the myogenic tumors. So we have smooth muscle, skeletal muscle, and then these so-called perivascular myeloid tumors, right? We have about a half hour left, good. So smooth muscle tumors, specifically leiomyosarcs. I know you're gonna talk about this in the gynae component, but of course we see this in the soft tissue. Of course we see this in the skin, coming from associated with your erector pili muscles. And of course we see this in the retroperitoneum, not coming from the uterus, right, but coming usually from a large vessel, like the vena cava, your mesenteric vessels. So just remember that to call something a leiomyosarc, it has to look muscular, right? It has to look like eosinophilic spindle cells in fascicles with cigar-shaped nuclei going at intersecting 90-degree angles to each other, and should have SMA, Desmond, right? If you have a tumor that doesn't look like the nice leiomyosarcoma morphology and really only has a little bit of SMA, what cell is that recapitulating? That's maybe trying to recapitulate more of a myofibroblastic-like morphology than a true smooth muscle. So just remember, wispy cytoplasm, nondescript, a little SMA, myofibroblast. Eosinophilic cytoplasm, 90-degree intersecting angles, cigar-shaped nuclei, think lyo, okay? Remember that sometimes they can aberrantly express keratin, so don't let that fool you. Just like a lot of sarcomas can aberrantly express keratin, we're gonna go through all of them in this talk. If you have an immunocompromised patient, you may want to throw an EBV on it because these tend to be better behaving if they're EBV positive. Retroperitoneal, oh yeah, the big box here. Retroperitoneal smooth muscle tumors can be ERPR positive even if they do not arise from the gynae tract. So fine, if they're positive, they can treat this patient with estrogen antagonists, but that shouldn't imply that it comes from the uterus. Okay, all right, skeletal muscle. So the benign rhabdomyomas. Remember that there's the one on the heart, which has these kind of glycogenated spindle cells, or spider cells, I should say, rather. Remember there's the one in the head and neck of adults, which is the just large striated cells. There's the fetal and the genital rhabdomyomas, which are both pretty rare, but have the strap cells, the tadpole strap cells. So they can be differentiated based on the morphology as well as the clinical location. Okay. Moving into the malignancies of skeletal muscle, embryonal rhabdo. So, characteristically, this light and dark mixed pattern. Remember that the botryoid variant of embryonal is just the protruding variant from an organ, like the mouth or the bladder, etc. You may see cross striations or just large eosinophilic rhabdoid cells. Remember, Desmond and myogenin myo-D1. For any of your tumors of skeletal muscle differentiation. Desmond myogenin, myo-D1. If you see diffuse strong myogenin staining in a skeletal muscle sarcoma, you may want to probe for the rearrangement that is often present in alveolar, i.e. Pax-Fox, right? So the morphology of a quote-unquote alveolar rhabdo, which is usually nested, usually large cells, right, usually with large nucleoli, sometimes with these kind of eccentric cytoplasm, right, that's alveolar. Sometimes alveolar can look like this, which is more spindly and variably cellular. If you start to see diffuse strong myogenin in this, chances are it's a spindle variant of alveolar. Chances are it has the translocation. Why do I care? Because of prognosis. So the aggressivity of the fusion positives is worse than that of the fusion negatives, okay? In the next slide, I've put your small round blue cell tumor differential. We've talked about Ewing's, right? We've talked just now about rhabdo. The one that we haven't really mentioned yet is desmoplastic small round cell tumor. in the intra-abdominal compartment of usually teenage males. Again, characteristic clinical pathologic thing. This is very aggressive. This looks like, again, another small round blue cell tumor, right? But what does it have different? All this desmoplastic stroma in the background. Why do we care? It has multi-phenotypic differentiation. It can stain with keratin. It can stain with myogenic markers. It can stain with neural markers. CD99, WT1, depending on which antibody you're using, can stain either the nucleus or the perinuclear area. These have EWSR WT1 rearrangement and super poor prognoses. So your comparison slide is listed here if you ever have questions. Okay, moving into the more ugly rhabdo. So the pleomorphic rhabdo is mostly of the adults. It's exactly as it specifies. It should have some spindle cell, rhabdomyoblastic morphology, but in other areas has this very pleomorphic look. Again, hey, look, may show nuclear MDM2 staining, but without actual MDM2 amplification, aggressive prognosis. The last type of rhabdo I'm going to talk about is spindle cell, which happens either in young paratesticular region of males or sometimes in adults in the head and neck. Better prognosis in the young, worse in adults. Basically a nondescript spindle cell neoplasm. You may make out vaguely some denser eosinophilic cytoplasm, you may not. If you see something like this that stains with desmin, you may want to throw a myogenin or MyoD1 on it to prove its skeletal muscle morphology, because it's not super obvious on the H&E that this is skeletal muscle. Okay, moving into the perivascular myeloid tumors. So, right, these are the ones that are around or near vessels or co-opt vessels to grow in them and stain with myeloid markers, SMA, sometimes desmin, right? So ranging either from your bland glomus tumor, very monotonous, small fried eggy cells, all the way to your myofibroma myopericytoma with these lobules around vessels, or your angioleiomyoma, which is very characteristically this mature smooth muscle whirling off of these vessels in a circumscribed manner in the distal soft tissues, okay? So just sometimes the morphology can be overlapping, but when you're kind of at the two ends of the spectrum, either the glomus or the angioleiomyoma, you're mostly dealing with small fried eggy cells or well-developed smooth muscle morphology. Okay, moving into the vascular tumors. So we, of course, have benign tumors of intermediate malignant potential, which are essentially the hemangioendotheliomas, and then the malignant ones. I'm not going to belabor all of the variants of hemangioendothelioma because there's a lot. So we're just going to focus on the one. All right, for the benign, we're going to start with infantile hemangioma, remembering that this is a rapidly growing tumor, usually in the postnatal few weeks, that can regress. The thing that is different about this from all the other vascular tumors is what? GLUT1, right? So if you see, it kind of looks like almost like a pyogenic granuloma, like a lobular capillary hemangioma, but it's got GLUT1 staining in the endothelium. Don't be scared when you see GLUT1 staining in the nucleus, in the nuclear membrane. Why do I keep saying nuclear? In the cytoplasmic membrane of the red cells, that's normal. The cells need the glucose transporter on the red cells, but make sure you're looking at the actual endothelium. Make sure you see a nucleus in there. That's GLUT1. That's an infantile hemangioma. Epithelioid hemangioma, sometimes called angiolymphoid hyperplasia with eosinophilia. Oh, right, because it's a very proliferative growth of capillary-like vessels with eosinophils and or inflammatory cells in the background. This can be in the soft tissue. This can be in the bone. It can look very juicy, like these endothelial cells are big with nucleoli, but they're kind of missing mitoses. They're kind of missing pleomorphism. They certainly will stain with your vascular markers, but aren't really considered aggressive, except for potential local recurrence. So epithelioid hemangioendothelioma, right now your intermediate malignant potential, also can occur in any site, visceral, bone, soft tissue, whatever. But what it is not vasoformative. So hemangioma, vasoformative. Hemangioendothelioma, not vasoformative, right? So you see strands of cells in this myxoid stroma. The only thing that's going to suggest to you that this might be vascular, perhaps, right, is maybe you'll see these little blister cells, right? These are the only vessels that this tumor is trying to form, which is an intracytoplasmic lumina, right? Sometimes you see a red cell in that intracytoplasmic lumen. Of course, these stain with your vascular markers, and like other epithelioid vascular neoplasms, can stain with keratin, okay? WWTR campta is the rearrangement. These can be aggressive, these can be multifocal, these can be metastatic, hence an indeterminate malignant potential. We don't entirely know which ones are going to metastasize. Angiosarc we'll also talk about. I just will remind you that epithelioid angiosarc, unlike EHE, is often basoformative, right? So remember one of these key morphologic differential diagnoses. We're also later going to talk about true epithelioid sarcoma, you know, the chromatin remodeling complex sarcoma, but I like to put charts in so you can look at this on your own. All right, so true angiosarcs are either primary cutaneous of the scalp of older dudes, usually, very infiltrated, very hard to get out, often has UV signature. Sorry, I shouldn't say no specific molecular. I should say these often present with UV damage because they're in the scalp of these old dudes. Deep lower extremities, sort of primary soft tissue angiosarc, often looks either vasoformative or solid, as up here. Primary breast, you've already heard about, can be very infiltrative in the deep tissues of the breast. Radiation-related breast angiosarc, of course, can be either in the, in the skin or in the breast with MYC amplifications. The other type of vascular sarcoma, can you guys hear that? Or did it not hear? Anyway, Kaposi's, if you're Dr. Kraus, you will say Kaposi, okay? This dude was Hungarian. So Kaposi sarcoma happens in a variety of different backgrounds, but the commonality is that they all have herpes virus. So HHV8, Kaposi sarcoma associated virus as seen here. They are spindled, elongated, extravasated red cells with little eosinophilic hyaline globules. They happen in these Mediterranean dudes, right? They can happen in African patients. They can happen after after solid organ transplant if these patients are immunosuppressed. But of course, they can happen in the context of AIDS and are an AIDS-defining illness, right? Otherwise, the morphology is all the same. All right, moving into nerve sheath tumors. Remember, nerve sheath tumors can develop from any component of the nerve, whether it be the perineurial cells, which are EMA group 1 positive, the Schwann cells, which are S100 SOX10 positive, or hybrid neurofibroma, all, right? The bottom line of all of this is MPNST, right? That is your basically your only malignant nerve sheath tumor that is of significant to discuss. So remember your variants of schwannoma. I'm going to list it here. Remember that sometimes AE3 can cross-react with GFAP, and so you make it keratin expression in this schwannoma. You have these variants of melanotic schwannoma, as in Carney syndrome. Most schwannomas, if they're going to transform to MPNST, is going to be the epithelioid variant of MPNST. Mostly schwannomas do not transform. What transforms are your neurofibromas, right? Especially your plexiform NFs in your NF patients, which is this beautiful, beautiful bag of worms. Histologically is also this multinodular undulating neoplasm. These are the plexiform neurofibroma lobules. These are going to transform to your MPNST. The other benign one is perineurioma. This is a more whorled type of neoplasm that has, of course, your EMA, your GLUT, your CD34 positivity, but because it's perineurial rather than Schwann, right, it's S100 negative. So don't think that because you have an S100 negative tumor, it's not potentially still a nerve sheath tumor. It's just a different component of the nerve sheath, potentially. All right, here's what your conventional versus epithelioid MPNST look like. Remember, conventional is kind of marbled, usually S100 SOX10 negative, in contrast to epithelioid, which is usually S100 SOX10 positive, sometimes keratin positive as well. Remember, your characteristic Triton tumor is just heterologous differentiation into skeletal muscle in your MPNST. You can have heterologous differentiation to anything, bone, cartilage, glands, okay. Here's your differential diagnostic table of your epithelioid MPNST, your actual melanoma, and your epithelioid sarcoma. Again, because you look at these three and you're like, oh my God, it's a solid epithelioid malignancy of soft tissue. What am I going to do? Evaluate for your melanocytic markers, evaluate for your nerve sheath markers, evaluate for your keratins, and perhaps for your INI1 if you're dealing with an epithelioid, perhaps sarcoma. sarcoma. We're going to get to that later. All right, don't worry. I just keep putting things again and again and again so you remember them in their various ways, shapes, and forms. Yes, this is like the giant category of these spindle cell fibroblastic, myofibroblastic lineages. It's okay. We're going to get through it. So we're going to start with nodular fasciitis, 11:30, 15 minutes. Okay. Remember, rapid growth, 2 to 3 months. This should not be a long-standing lesion. Can be circumscribed or infiltrative. Is defined by its myofibroblastic phenotype, SMA positive, and USP6 gene rearrangement. Here are the other tumors that are USP6 rearranged, right? ABC, sometimes myositis ossificans, sometimes fibroma of tendon sheath. Here's nod-fash, myofibroblastic wispy cells. I'm sorry, I like to mime things. Wispy cells with microcystic spaces, with keloid-like collagen, with extravasated red cells. This is nodular fasciitis. Always think about it when you're dealing with spindle cell, kind of bland, nondescript, wispy neoplasm. Other fasciitides are listed here: proliferative, intravascular, cranial, ischemic. They can have in common these ganglion-like cells and should be differentiated essentially by their location, their clinical context. I'll let you read this on your own. Desmoid, right? We see desmoid not infrequently, often in the abdominal wall of young pregnancy age or post-gestational females, sometimes associated again with Gardner syndrome, right? So what do we think? Beta-catenin. So long, sweeping pale cells and fascicles with compressed blood vessels, as seen here, with beta-catenin in the nucleus, right? In the nucleus of these tumor cells. Here's your classic myofibroblast appearance. If I haven't said it enough, probably not. I'll say it again. Elongated nuclei with small pinpoint nucleoli with kind of this wispy pointed cytoplasm. That is characteristic myofibroblasts. Other fibromatoses that are less common include superficial, like your Dupuytren's in your hands and feet. These are less commonly associated with beta-catenin. Fibromatosis coli of your neck, juvenile hyaline, infantile digital or inclusion body, and so-called lipo. I'm going to let you read these over. These are extremely rare. I have no idea if they're going to come up on your boards, but something like a weird infantile or inclusion body, may, because it's so characteristic with these little perinuclear inclusions. Okay, now fibromas. Just like there are multiple types of fibromatosis, there are multiple types of fibroma. So you should never call something a fibroma without qualification. Fibroma of tendon sheath, nuchal type fibroma in the posterior neck, Gardner fibroma, which is beta-catenin, right, positive, often in the head and neck of young kids. Elastofibroma is that thing behind the scapula of elderly people that has elastic fibers that you can pick up, this beaded elastic that you can pick up on elastin stain, and then calcifying aponeurotic fibroma of the palms of kids, right, with this kind of calcified material in the center and these histiocyte-like cells on the periphery. I will, make us think about these morphologically similar lesions that can occur on the distal extremities of various aged people, including the calcifying aponeurotic fibroma of kids, including the rheumatoid nodule or granuloma annulare of adults, including the worst thing, which you of course want to pick up in adults, is going to be epithelioid sarcoma, which can have a pseudogranulomatous appearance on the distal extremities. But what's going to be different about this? Keratin, 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 keratin. These are histiocytes and sort of myofibroblasts. Okay. All right, moving into our next category of these hypocellular myxoid stromas. I know we're going to spend a minute on low-grade fibromyxoid sarcoma versus myxofibrosarcoma. So LGFMS is by definition a low-grade tumor occurring on the extremities of young adults, has these discrete myxoid and collagenous zones, is generally paucy to moderately cellular, and is defined by Fuss-Krebs rearrangements. Okay, this is in contrast to myxofibrosarcoma, which can be of any histologic grade, low, intermediate, and high, often on the elderly, often in extremities, often highly infiltrative, with these curvilinear blood vessels with highly atypical cells, large, dark, hanging off of the blood vessels. Compare that to the more relatively bland morphology of low-grade fibromyxoid, okay? Low-grade fibromyxoid, as I said before, is defined by that gene rearrangement, but you can also test for IHC, for EMA, and MUC4 before you go probing for the genes, right? So this is an easy test to do to consider LGFMS. Myxofibrosarc, of course, would be negative for the IHC and the gene rearrangement. Myxofibrosarc, you would grade, just like you would grade any other soft tissue sarcoma, by the French system. Okay? What low-grade fibromyxoid on the left can do is it can transform to so-called sclerosing epithelioid fibrosarc, retaining EMA, retaining MUC4, and retaining the genetics. You can also have a pure sclerosing epithelioid fibrosarc that does not transform from LGFMS. What they all look like is these very plump cells in this collagenous stroma or solid sheets. Sometimes you might think about lobular breast cancer, right? So you're looking at this and you're like, that's a little bit like lobular. The cells are a little bit weird. Or you might think, is that osteoid? Could I be dealing with an osteosarc? Those are all great differential diagnoses. Do your keratins, do your EMAs and your MUC to differentiate from a carcinoma, from an SEF, from an osteosarc, which should not be EMA or MUC4 positive. Okay, more charts. Look at it on your own. Of course, synovial sarc. Synovial sarc is a misnomer, even though this happens around large joints. It is nothing to do with synovium. It is around the large joints, usually of kids, can often be in the deep tissues, can be in the head and neck, can be in the lung, can be anywhere. Okay, so remember, HPC-like vessels, thin-walled and dilated. Remember, can be monophasic or biphasic, biphasic with epithelioid islands. Remember, should have EMA or keratin positivity. Remember, should have TLE1 nuclear staining, but TLA1 is not so specific because a lot of things can express TLE1, unfortunately. Always rely on the translocation SYT, SSX1 or 2. Hey, SFT, here we go. So we talked about SFT in the head and neck. Again, I'm not going to recapitulate it. Just remember, most common site is, of course, off the pleura of the lung, but can occur in deep soft tissue. Remember STAT6, remember CD34, remember hypoglycemia due to secretion of IGF-2 by the tumor. IMT, or inflammatory myofibroblastic tumor, is another one of these, hey, I'm a nondescript kind of spindle cell lesion, but what do I have with me? I have lots of inflammatory cells. Sometimes I have these ganglion-like cells, and sometimes, if I'm lucky, I might have ALK rearrangement, and you can see ALK positivity on IHC if you're lucky. The behavior is very variable depending on whether you're a pediatric or an adult and whether you have the ALK rearrangement or not. So fibrosarcoma is essentially this very cellular spindle cell herringbone tumor that, when it occurs, this morphology in a kid, you're basically dealing with infantile fibrosarc, ETV6, and TRK3 rearranged. If you're dealing with this morphology in an adult, this is pretty rare on its own. You might want to actually think about a transformation from DFSP, which looks exactly like this long herringbone fasciculated thing, okay? Yeah, okay, ETV6 and track rearranged. Once you've excluded all other named sarcomas with differentiation into any sort of category, you can't prove anything else, you're left with undifferentiated sarcoma. Formerly MFH, of course that term is no longer used. This has no specific genetics. It's a pretty aggressive but relatively common sarcoma of adults, can have giant cells, can have spindle cells, pleomorphic cells, can look very varied. Another chart for you. Okay, remember epithelioid sarc has both a proximal and a distal type. The distal is those granulomatous looking lesions on the digits. The proximal type is this ugly sheet-like growth in your trunk and local, proximal extremities. All of them have keratin, strong keratin, and all of them have loss of INI1 by genetics, okay? So don't let the keratin fool you. Always think about keratin expressing sarcomas. Okay, here's again a chart of that differential diagnosis. Remember the distal extremity granuloma-like lesions, calcifying aponeurotic in kids, granuloma annulare or rheumatoid nodule versus epithelioid sarc, keratin. Okay. All right, what's malignant extrarenal rhabdoid tumor? Well, this is another one of these epithelioid, perhaps keratin expressing neoplasms, certainly INI1 lost neoplasms, mostly though in the kind of paraspinal deep axial region of kids, sometimes in the brain. Very similar to epithelioid sarc morphologically and genetically. Can distal type epithelioid sarc be seen in other locations? As a primary, not usually the characteristic is here. I mean, certainly anything can happen anywhere, but if you start seeing it like in the axillary or the inguinal like lymph nodes, that's a metastasis, because these are the ones that can and do metastasize to epithelioid sarcs. So maybe, but just throw on an INI1. If you say INI1 lost, your differential diagnosis is super narrowed, and that should be able to at least help you. All right, here are your INI1 lost tumors. Speak of the devil, right? So your list is short and should be differentiated based on immunostains and location, etc. Just a word on the chromatin remodeling complex process. We know that both INI1 and BRG1 are of the similar function in the cells. We have immunostains for both. I tend to do them both because the morphology of these tumors can be overlapping, and we're learning a lot about both of these. So here we go. All right. Oh my God, 11:40. I'm so sorry. You have 5 more minutes. Keep typing your stuff in the comments. I'll get to your question. Alveolar soft part sarcoma, just like its name suggests, alveolated, nested, right? Characteristically related to TFE3 rearrangement, so that's what you're going to want to probe for. But again, this large cell, prominent nucleoli, I'm not going to repeat this morphology over and over again because you see it. Sometimes they have Desmond, and sometimes they have these PAS positive rhomboid crystals. Again, Bohr's maybe like electron microscopy. That's alveolar soft part crystals. Clear cell sarc is your melanoma of soft tissue, right? Not really melanoma, but stains like a melanoma, kind of looks like a melanoma, but is in the deep soft tissues of the distal extremities and has EWSR ATF gene rearrangement rather than any of the melanocytic markers, melanocytic genetics, not BRAF, not NRAS, not c-KIT, right? This is EWSR rearranged, and there should be no melanoma in situ above it. Also one of the ones that goes to lymph nodes. All right, PCOMA is your tumor that shows both melanocytic and myogenic differentiation. So perivascular epithelioid cell is what the PEAK stands for. Just remember hybrid differentiation with this, again, characteristic morphology. All right, if you have an epithelioid tumor with a myxoid background, you're going to be dealing with one of 3 things: a myoepithelioma of soft tissue, a chordoma, which should really only occur in the base of skull and the sacrum, where your notochord opens and closes, or an extraskeletal myxoid chondrosarc. And you can differentiate all of these by, do I have it here? I might, or may, excuse me if I don't, but you should be able to differentiate these by immunostains and or genetics. So myoepithelial, you need to show keratin or EMA and some kind of myoepithelial marker. Chordoma, you need to show keratin and EMA and S100. And if you're lucky and you have brachyury, which is your notochordal marker, do that. And epithelioid, extraskeletal myxoid chondrosarc has your EWSR NR4A3. NR4A3 is the one you want to remember, rearrangement with some variable, non-specific immunoprofile. Okay. All right, I'm going to let you look at those charts on your own. I put these together because they can be difficult to distinguish from each other. So just read the chart over. Let me know if you have questions. How common is myogen and MyoD1 seen in D. diff liposarcs? You shouldn't really see true myogenin. At least I've never seen it. I've seen SMA expression with myogenic differentiation in D. diff liposarc. But I've never, it's a really good question. I don't know that I've seen or done the myogen and MyoD1 in D. diff. Because you're asking about the MDM2. Yeah, good question. We'll get back to that. All right, in the last few minutes, oh, you know what? While I'm here, can I answer the other one? So do gnathic osteosarcomas have a worse or equivalent prognosis when compared to conventional? It depends on the resection status. If they are resected with negative margins, they tend to do okay. If the grade is higher, that's certainly more worrisome, and they are less responsive to chemo, right? So if you're dealing with a high-grade long bone and a high-grade gnathic that's not resected well, that's gonna be bad, because it's non-resectable and it doesn't respond to chemo. Once you've treated a long bone with chemo and it responds, those can be very responsive to chemo, but they also can come back years later and go to lung, right? Even if they've responded on the first time. So it can be difficult to necessarily sort out prognostic differences in those because it's so many factors. Okay. So it's 44. What do you want me to do? I can let you guys go on these skin tumors on your own. We basically have dermatofibroma and variants. We have DFSP with fibrosarcomatous transformation. We have giant cell fibroblastoma, which is your variant of DFSP in kids. Juvenile xanthogranuloma. We have your dermal-based spindle cell neoplasms. The one thing, I will say one thing about atypical fibroxanthoma versus dermal sarcoma, which is this is superficial and this has deep extension, okay? So just be cautious, read my slide over. This is super rare. Giant cell rich tumors, I think you're mostly familiar with, tenosynovial giant cell tumors. Remember that the old name was PVNS in the diffuse type of giant cell tumors that you see carpeting the joints, right? The name has now changed, but who knows what the boards are gonna ask you. I think these are all pretty rare, so I don't really need to worry about these. Phosphaturic mesenchymal tumor may be a rare bird that the patient has rickets, right? Or the patient has phosphaturia, osteopenia. Think about phosphaturic mesenchymal tumor. Yeah. How do you differentiate pleomorphic liposarc versus undifferentiated sarc? Is it S100 on lipoblast? How do you differentiate pleomorphic liposarc? Oh, so usually your undifferentiated sarcoma usually won't have adipocytic differentiation, interestingly enough. So otherwise you can't. I don't think the S100 is not very reliable in my experience, but it's morphology. So if you think something truly has pleomorphic lipoblasts in a background of undifferentiated spindle cell, it's probably a pleomorphic liposarc. If you don't see the pleomorphic lipoblasts, it's probably just an undifferentiated pleomorphic sarcoma. So I think it's really mostly morphology because the karyotype is non-specific, the genetics are non-specific in either case. Other questions?
I'm available.
Absolutely fantastic. Wonderful. That was such a good review. I think I can sign out the bone and soft tissue now.
Excellent. That is my hope for everyone who listen to this call, that they can feel at least comfortable triaging these cases.
Dr. Cipriani, can